Welcome to the Breast Cancer Network Australia interview, Understanding Genetic Testing. My name is Megan Walker, your host. I'm joined today by special guest Dr. Michael Gattas, who's a clinical geneticist with Brisbane Genetics. Hello, Michael, and welcome.
Thank you, Megan.
Michael, this is our first video in a series of 3, as you know, and this one is going to be quite our basic introduction to understanding genes and genetic testing. So would you like to start us off, just for people who are not familiar with this topic at all, by just explaining what actually genes are?
Genes are what we inherit from our parents. And so most of our genes exist as a pair. You get one copy of each gene from your mother and another copy of each gene from your father. We have about 20,000 genes all up. And I guess technology of gene testing is progressing. So it's making the testing cheaper and easier.
Okay. And now, for most of the people listening to this interview, they might have an experience with breast cancer. So can you explain what the breast cancer genes are?
Yes, they're probably 2 of the best known genes. They were called BRCA1 and BRCA2. They were discovered back in 1994 and 1995, respectively. And I guess there's been a lot of testing of those genes now take place internationally, over 20 years, really, in families with breast cancer. So we do know quite a lot about those genes and some of the less common genes that can also predispose to breast cancer.
Okay. I've heard them called BRCA1 and BRCA2. Is it okay if I use those terms as a lay person to try and remember? We
often hear them used, but I actually heard Mary Claire King, who discovered the BRCA1 gene, refer to it as BRCA1. So if you do use the term BRCA, don't tell her. She's quite specific. Oh. They were called BRCA1 and BRCA2, so she's got quite a firm view on that issue.
Oh, good. So if someone has breast cancer, do they then definitely have BRCA1 or BRCA2?
It's a good question and important to point out. No, most cancer, breast cancer included, fortunately is not due to inherited gene defects. So the women with breast cancer which do have an inherited fault in BRCA1 or BRCA2 really only make up a small proportion of all the families we see. And the majority of people we test, we usually can't find any inherited cause. So I use the terminology the cause remains unexplained, or sometimes people refer to it as inconclusive result, meaning we haven't been able to confirm an inherited gene defect. So the inherited genes only explain a small proportion of individuals with breast cancer.
Okay. So in that case, somebody diagnosed with breast cancer, should they get genetic testing?
It's a good question, and there's no one right answer to that. It depends on factors such as age of diagnosis. So if you're less than 40, it is a higher chance of finding an abnormality. It does depend on family history. If you've got other relatives either with breast cancer or men with breast cancer, and particularly if there's any ovarian cancer or possibly pancreatic cancer in the family, they also are associated, at least to some extent, with BRCA1 and BRCA2. Interestingly, things like Jewish ancestry is relevant. If you're Jewish, you have more chance of having a BRCA1 or BRCA2 gene fault, and bilateral disease. That's another important factor. So the specialists who will ask you about family history will be looking at that information to determine if we've got a good chance or not of finding a gene fault.
Okay. So can genetic testing help me know if I will pass my cancer on to my children or not?
Yes, it's one of the important reasons many women are keen to be tested for the sake of their children. If you don't have a gene fault, then you can't pass it on. But it is important to emphasise that an unexplained family history still means your children need to be careful with breast checks. So the fact we haven't found a gene fault doesn't necessarily mean your children will be at low risk. But if we have found a gene fault in that woman or man, so you do inherit a copy of each gene through your mum and through your dad's side, their children have a 50-50 chance or 1 in 2 chance of inheriting the abnormality.
Okay. And what about skipping a gene? Can genes, say, go from a grandmother to a granddaughter?
Again, good question, because a lot of people ask the same thing. No is the short answer to that. So you can have a gene not cause the health problem, though. So there are women who can carry a BRCA1 or BRCA2 gene defect and never develop either breast or ovarian cancer. Those two are important for ovarian cancer as well. So it would appear to skip a generation if she never developed the cancer, yet her children could develop breast or daughter's breast or ovarian cancer, even though she did not herself have it. Or, of course, it could go down through a father who doesn't have much increased risk of cancer, and he passes it to a daughter. So it looks like it's skipped, but in fact, the person who had the gene fault doesn't always develop the cancer.
Okay, right. That makes sense. Thank you. I always wondered about that one. So what's involved in genetic testing? Do I have to go into hospital? If I was going to get it done, what's the process?
Most commonly, it still involves a blood test, although increasingly we're using saliva samples to collect healthy cells. I do quite a bit of testing with overseas for a company, and we send the saliva away. We're basically testing normal cells to see if there's an inherited fault. It does have to be requested through a specialist. At this stage anyway, Medicare item number, which became available on 1 November, restricted the requesting to a specialist. That could be a genetic specialist, an oncology specialist, or a breast surgeon, for example, would be the type of specialist. Sorry, a gynecologist is the other type of specialist because of the ovarian cancer. So usually it's through a specialist, and it's usually a blood test.
Okay. And do the results affect how I would be treated?
Again, an important question. In most instances, no, but there is a class of drug known as PARP inhibitors. Now, this is if you've actually got cancer, and it's usually a second line, not a first line chemotherapy. So possibly in the metastatic setting, for example, if you've got an inherited fault in BRCA1 or BRCA2, it does suggest you could respond better to that type of medication. So we are increasingly being asked to test women by their oncologists, really, because it could make a difference in what type of chemotherapy. But in the initial point of diagnosis, usually it doesn't change whether they're going to need chemotherapy or other treatment.
Okay. And so from start to finish, how long does genetic testing take, and would it delay a person's treatment?
It's about 4 weeks is the typical turnaround time, and it can be done more urgently if needed. And the reason perhaps for an urgent test, I'm thinking about would it change treatment decisions? It's more to do with decisions about radiotherapy and mastectomy. So if you knew you've got a high-risk gene for breast cancer, then there's a stronger case to go down the path of the mastectomy, probably bilateral mastectomy, in order to protect you from developing a breast cancer in the future, not just treating the breast cancer that you've got. And if you're doing reconstruction, it's easier if you've not had any radiotherapy. So if you have radiotherapy, then it does make some options for reconstruction more difficult. So sometimes the surgeons want to know right at the beginning in terms of whether you're going to go down the mastectomy pathway or not. And that's probably the reason we do an urgent test, not necessarily because it will change whether you need chemotherapy, but if you do have mastectomy sometimes, not always, but sometimes you can avoid having radiotherapy as well.
Thank you for that. And what does it cost?
If it's Medicare rebatable, then Medicare will pay for the testing. So that only became available from 1 November last year, or through public hospital clinics. Most testing is done through public hospital clinics, and the hospital pays for it. Patients I see privately spend about $400 to do BRCA1, BRCA2, or in fact I often do a panel of genes of 30 genes, and it costs at the moment about $400 to pay for it as a private patient.
Okay, thanks, Michael. And I've got 2 more questions, and then we'll wrap up this one. So if someone gets breast cancer genetic testing done, does it also come back and tell them if they're at risk of other cancers in the future? What else could it possibly tell them?
The 2 main ones for BRCA1 and BRCA2 are breast and ovary cancer. But BRCA2 is an important risk factor for men for prostate cancer, and a little bit for pancreatic cancer. So they're the 2 main culprits. But the panel of genes I mentioned that I did earlier does look at many other genes at the same time. So some for bowel cancer, some for melanoma. That's not been common at this point, but I think it's going to become increasingly common that it will look at other cancer genes just because the cost of doing that is now more affordable. So once you've done 2 or 3 genes, the cost of doing 10 or 20 genes is not that much different.
Interesting. And then I wanted to wrap up with any insurance issues. and how that works if someone's getting genetic testing done? Do they need to tell their insurance company before, during, after? Tell us about that.
Again, an important question. So it's important to say that existing policies, I'm talking about life insurance, income protection type policies, aren't affected. So current policy holders don't lose any policies they've already got, and no medical insurance is affected. So you don't have any difficulty getting medical insurance, or family members don't have difficulty getting medical insurance based on gene testing results. But if you do have a parent or a sibling with a high-risk breast cancer gene, that is information that insurers will expect you to declare when you take out the policy. So the discovery of a high-risk gene, that piece of information alone can make it harder for you to get life insurance or income protection insurance. And that's even though you've never been tested. And you may not even have the gene. You're only at 50% chance. But they will still either knock you back, or you're going to have to pay more for the policy. The policy could have an exclusion on it, or they could cap the payout. So it does potentially affect some future life insurance policies as it stands in Australia at this time.
Okay, thanks, Michael. So this discussion has been all about the basics and understanding genetic testing. We're going to have another interview that should be easily found closely where this one's housed, where we're going to talk about what to do with the testing results and the implications for family members. So we'll go into a bit more detail in that in our second interview. But Michael, is there anything else that patients commonly ask you, frequently asked questions that we haven't yet covered that would be important for people to know about when they're understanding the basics?
The other issue I always raise is the increased threat or anxiety that discovery of a gene fault found. So the downsides that I usually raise are, one, to do with insurance, which we've asked about, but it really isn't good news to tell somebody you've got a high-risk gene for cancer, and it can add to their worry, particularly at a time when they've already got a lot on their plate. So not everybody wants to know if they've got such a gene fault. So it is, important to think about that carefully and not burden people more with what could be a difficult thing when they're already struggling. So the timing of how and when you'd find out, I think, is actually something that you can have control over.
Fantastic. Okay, thanks, Michael. So in closing, we've been talking today with Dr. Michael Gattas, who is a clinical geneticist with Brisbane Genetics. And thanks very much for your time, Michael, and we'll see you in the next interview.
You're welcome. Thank you, Megan.